you've been involved in some of the de-escalation studies. What is the clinical rationale for exploring de-escalation strategies with EV Pembro in metastatic urothelial carcinoma?
Yeah, so as you know, EV Pembro has really changed how we treat metastatic urothelial carcinoma, with it being the frontline standard approach that we have. And you know that the treatment is very efficacious. It has an overall response rate of like 67% based on EV-302. But this medication does have some significant toxicities that are more cumulative. So, for example, in EV-302, 60% of the patients had grade 3 adverse events, and about a third of the patients needed to discontinue the drugs. And peripheral neuropathy tends to be one of the common toxicities of concern, which is of cumulative nature. Typically tends to occur, after 3 to 4 months of receiving the treatment on an average. And about almost half of the patients on that study developed neuropathy. And so I think, that is one of the reasons, one of the limiting factors that leads us to, wonder if patients need to be on EV and pembrolizumab continuously, as was done in the EV-302 trial. There are some additional rationale that I could suggest, in addition to obviously that it is a toxic drug, is that, as we have been giving this in clinical practice, and now we also have data from the completed prospective trials, that there is indeed rationale to de-escalate. So, for example, we have long-term data from EV-103 cohort A, which was a frontline cis-ineligible EV Pembro cohort, a smaller study, but we do know data from there which showed that patients discontinued EV Pembro by 2-year mark due to toxicity, yet responses persisted well beyond drug cessation, suggesting that long-term disease control can be achieved without continuous treatment. And we do see this in our clinical practice as well now. And, similar data was also, I think that it is not just the fact that EV is given with Pembro, and it's because even just in the EV monotherapy trials with, like EV-201 cohorts 1 and 2, even in those studies, you can, if you look at the swimmer's plot, in EV-201 cohort 2, like 50% of the patients maintained disease control beyond discontinuation. It partly may have to do with the fact that, there is some MMA-induced immunogenic cell death, which then, activates the immune system, and that in combination with an anti-PD-1 therapy agent really becomes synergistic and may potentially be leading to these durable responses that we are seeing.
That's wonderful.
There is one more kind of piece of information that was presented by Dan Petrilak last year, where he had analyzed the EV-301 data, which suggested that an initial EV dose intensity, that really is crucial for efficacy. And then, over time, reduction of EV exposure, is just as good, in terms of the efficacy that is achieved in the different quartiles of dose exposure that he had shown.
And based on that data that's available now, are there any patients that you start off with a dose de-escalation?
So the absolute dose, we do have some patients, especially the weaker patients, we may want to start them at 1 milligram per kilogram of EV. That is something that we commonly do. Yes. So okay. although in general, I do like to try to give the patients a good intense dose in the beginning if possible.
Right. Based on Dan Petrilak's data that supports the idea of doing that.